I'd like to introduce myself. I'm Dr. Stephen Dion, and I am going to take you through the filler portion of the CME course, Fillers, Neurotoxins, and Beyond. And in this portion of the course, I'll take you through preparation of the product, anesthetic techniques, injection techniques, and tips and pearls for getting fantastic results. To start, I'm going to show you how we go about preparing to treat the patient by first looking at the products that we use for anesthetizing the patient and getting them all ready to go and getting the products out of the packages. So we start with, these are some of the things that we have set up when we're ready to treat our patient. These are already prepared in the room. For anesthetic techniques, we often have our anesthetics set up, and if we're going to do perioral treatments or around the lips in particular, I will do a nerve block. And for the nerve block, I use Septicaine. This is my treatment of choice. I used to use lidocaine with epinephrine, and I used to use lidocaine without epinephrine. I find that I prefer Septicaine because the Septicaine does not last as long, and it's got a much higher pH, therefore it doesn't hurt when I'm injecting it. And the epinephrine, I believe, may help with some of the bruising. To prepare the Septicaine, we use a dental syringe, and the Septicaine comes in ampules, 1 cc ampules, and we use a 27 gauge needle, which we break its seal, and we just screw that into the top of the dental syringe. I load the ampule, and I have it ready to go. And this is sitting by the patient, so when I walk into the room, this is already prepared to go. I have my gloves. I also occasionally will use these topical anesthetic products. This is a ethyl fluorochloride, and this product can be used to refrigerate or to freeze or to significantly decrease the temperature of the surface of the skin so the patients don't feel the injections as much. However, it does not work for the deeper dermal tissues, so they still will feel some pain, but it's something that we can use for patients who are uncomfortable with the feeling of a nerve block. We also use a topical anesthetic occasionally for tough to reach areas where we may place this on the skin and allow this to sit on the skin for 15 to 20 minutes and will help with some of the superficial discomforts of injecting, especially for injecting superficially. To prepare the product, what I do is I take it out of the box, open the canister, and in sits the syringe of hyaluronic and a needle which comes with it. This needle is a 30 gauge half-inch needle, and you can use this needle, or oftentimes I'll prefer my own needle, which I like a 30 gauge B&D needle. I prefer this one, so that's what I use. Some people use the 30 gauge needle that comes with the package insert. When removing the cap, you have to be very careful here. There's a cap here, and then there's a hub. You want to unscrew this cap gently, and you don't want to touch this hub. If you touch this hub and weaken this hub and loosen it, you risk that the needle will pop off during the treatment, and that's never very nice. So I remove the stopper. I take off my 30 gauge needle, and it's very important how I do this. I just twist this onto the end without actually touching this hub until it's tight. You don't want to over tighten it because you'll strip it, so just tight, and now that's ready to go. Once again, if you manipulate this too much, it'll loosen, and then it becomes at risk for popping off during the treatment, and that, once again, that's not fun. So I also have an alcohol pad ready to go to clean off my patient. And we have an ice pack ready to go for after the treatment. So these are some of the things that I have ready to go prior to me treating the patient. So this is the patient we're going to treat with fillers today, and she so generously donated her time, and she's allowing us to demonstrate how we do fillers on her. And she's a great candidate, and I'm going to show you techniques and tips and pearls for getting great results. First thing we do when we see the patient, her makeup has been removed. She's had photographs taken. We always do pre-treatment photographs. We think that that's necessary for multiple reasons. It's part of the documentation process. In addition, patients sometimes forget what they used to look like, and we too also forget what they look like. So that way we can refer back. and it's also great for learning. So we make sure that she's cleaned off everywhere that we're going to treat her with fillers. So we clean off the whole area, and we use an alcohol pad. It's important that you do clean her off everywhere. You don't want to get an infection. I have seen an infection before with hyaluronics, which I treated effectively with antibiotics, but you don't want that to occur. So you want to make sure that you clean off all areas to be treated. Now she's been already prepared by my assistant, but I'm just kind of showing you using the alcohol to make sure all the areas are clean. We last over the lips where that doesn't smell or taste so good. So the first thing we do when we evaluate the patient is we look at them and we try to determine where they best could use filler. Now, of course, the patient's a very big part of this, and I ask her what concerns her, and she gives me some clues into what she wants to treat. But we take a good look at her. We evaluate the symmetry of her face. We look for areas of volume depletion, and with the aging process, there's a significant amount of volume depletion. So we want to make sure that we restore the areas that have lost the natural fat and soft tissues of the face. And we look overall at her symmetry. Her thickness of her skin is also important, and her lips and the fine creases and irides of the face. Now, I use the hyaluronics. There's two different versions that I use. There's one that's a thicker version and one that's a thinner version. And the thicker version we place deeper for volumizing, and the thinner version we place more superficially for some of the finer creases and lines of the face. So I look all over, and I'm helping to determine myself what I'm going to use where as I diagnose the areas of concern. So I'll have you frown your eyebrows, and you can see the glabellar area. That's an area that I will occasionally treat with fillers. I like to use it in combination with a neurotoxin. I think the combination works wonderfully, and in fact neurotoxins are my treatment of choice for this area, but occasionally if I cannot get rid of those lines, I will treat it in combination with the filler. One of the things you can do is you can spread the creases apart, and if they don't come, if you can't see them being eradicated by this maneuver, then you do want to, then fillers is an option or indicated. For her, she could use maybe a little bit of filler, but she should get a nice result with botulinum toxin in that area also. I don't use fillers in the upper forehead region. I don't think it looks very good in there. It can leave fine lines. I do place filler underneath the brow. It will give the appearance of a brow lift by placing filler in this region right here. The lower eyelid is another area where she has slight hollowing out, and this is a combination of loss of fat and soft tissue in this region and cheek patosis. As this cheek descends, you start to see this nasojugal groove and this infraorbital trough, and that area can be treated with filler also. However, it's not so simple to treat that area, and I will tell you that I spend more time now taking out filler from that area which was placed in there poorly than I do putting it in. So you do have to be very careful how you treat this area. I'll go through some of my tips and techniques for getting a nice result in that area. You also, one of the most common areas for me to treat are the nasolabial folds, and this is an area I treat with filler, and we get fantastic results that are long-lasting in that region, and it's the area of the face that is FDA approved for cosmetic use of the hyaluronics. The cheek area is another area you can treat, and in this area I'll use a thicker version of the hyaluronic, as I think that this is a nice area to volumize, so I'll place it in this region. I also may place a little bit in this hollowing out of the cheek if necessary, as I fan it out from the zygomatic area down into the cheek. The lips are another nice area to treat with the hyaluronics. I think they work very nicely here. It's very natural appearance. It will help break up some of these fine lines as they reach the vermilion. So I will place a threading method around the lips, and I'll show you those techniques. And that's another area to treat well in combination with a neurotoxin. The mentolabial sulcus is an area patients frequently don't ask about or talk about, but if I have a little bit extra at the end, I may place it in this area, and it will look very nice in that area too. The prejowl sulcus, which is this region right here, which is an area that I may frequently treat, especially for someone who has significant jowling and they want to have that appearance of a nice streamlined jaw. And by placing a little bit in there, it gives the appearance that you've lifted the jaw, or lifted the jowl, even though you haven't really done that. But by filling this area in, it gives that appearance. So that is another area that I frequently treat. The nose is an area I do not frequently treat with hyaluronic, but some people do. Rarely will I place hyaluronic on the nose, but occasionally I have. I'll also show you a little tip and technique for turning up the corner of the mouth that can look very nice. There's not much indication in my practice for treating into the neck region, so I'll show you those upper third regions and lower third that I treat. But overall, as you can see, she's a good candidate for filler in the mid-face and some in the lower face, and those are the areas we'll concentrate on, but we'll also treat the upper third at the same time. First I'm going to do is I'm going to numb her. Now the numbing technique, there's lots of different ways to do this, and I prefer a nerve block if I'm going to treat the lower third of the face. So when I first walk into the room, after we've already determined what we're going to do and how many syringes and which areas, I will then go ahead and proceed with the nerve block. I'm right hand dominant. I stand on the patient's left hand side. I bring the chair back a little bit. Just back a little bit. Okay, good. And I have the chin up. Now, where I'm looking to treat is the infraorbital nerve, which is right about there. And I recognize that from spending a lot of time in surgery. I know where that's at. But if you follow the mid-pupillary line down, it's about where the infraorbital nerve is. Follow that tangent down is to where the mental nerve is. And the supraorbital nerve is in this region. But I want to have that infraorbital nerve anesthetized and the mental nerve anesthetize. So I'm looking to treat those areas. I don't want to inject the foramen directly, but I want to inject near the foramen in order to get a complete nerve block. If this is appropriately anesthetized, then the whole upper third of the lip will be numb. Occasionally, and I would say about 10 to 15% of patients, there's some confluence of nerves endings in this region, and I may have to do an additional block underneath the subnasal sulcus in order to treat the area. I'll show you exactly the areas we're treating. You can see here on the skull, Q-tip. If you look on the skull, here's where the infraorbital nerve sits, the mental nerve sits. So I want to treat these as they come out of the foramen, but I don't want to inject in the foramen because there's risks with injecting into the foramen and intravascular injection, which I don't want. Here's looking on the bone. So I go up into the canine fossa, and my preferred technique is to go intraoral, and I'm injecting right about there. My needle touches the periosteum, and I deposit a quarter of cc, 0.25 cc of Septicane in that region. So I don't want to inject the foramen, I want to inject right about there, and I'm aiming up infraorbital. Same thing here, infraorbital. When I go into the mouth, into the gingival buccal sulcus, I will look here for the second premolar. Follow the second premolar down and inject a little bit right there, just above the mental foramen. And that's where I'm looking to do a technique to anesthetize the whole lower lip. Now, I have another trick, and that's using this. And this is a little personal massager, and I don't have any financial interest in this company. But what I do is we place this onto the cheek, and we use it as a distraction device. And it's a wonderful trick. And oftentimes patients will tell me they don't even feel the injections when I'm doing it. This works really great to distract the patient and the nerve so they don't feel the injection. There's two different ways of doing this, and I'm going to show you both ways. But I retract the upper lip, and I place the distraction device onto the cheek. Now it's actually sitting down on the zygomatic arch. It's vibrating the bone. And I'm injecting, I go up into the canine fossa, and I'm shooting for right there. That's where I'm aiming for. So my needle is now on the bone, and there's the foramen, and I'm just below it. And I'm going to inject about 0.25 cc's. And that's it. And that should anesthetize the whole upper lip. Now an alternative method, in order to anesthetize the upper lip, I'm going to show you on this side, is to do a transcutaneous. And actually transcutaneous is a bit easier to do. So if you're just getting started with these nerve blocks and you're a little concerned about how to do them appropriately, you can go transcutaneous. So what you do is, I look at where the triangle here is of the nasolabial crease where it comes into the alar insertion. And if you go just lateral, about 1 centimeter, and you inject down to the bone, and deposit a quarter cc, that'll work just as well too. Now the downside to that is you have to go transcutaneously, and patients will feel that. It hurts a little bit more. If you go intraoral, they really feel very little. And in fact, for those who want to feel absolutely nothing, you can place a topical paste into the intraoral sulcus, and by placing that paste in the intraoral sulcus, it'll numb it completely. And it's a benzocaine solution that we sometimes will place into the intraoral sulcus, and that will help reduce any sensation of discomfort. Now, some people will do micro blocks, where you just place little injection aliquots along the gingival bulcal sulcus, like such. And this is another way of doing it. I don't use that method. The advantages to that method are that you have much less of a nerve block, and sometimes patients can feel a little bit uncomfortable with this nerve block. So for those who are uncomfortable, you can do those micro injections, but I tend to prefer to use a complete nerve block. Now we'll do the lower lip. So I retract the lower lip. I follow the second premolar down to the foramen. I don't want to inject the foramen. Now I'm next to the foramen. Injecting right next to the foramen. I can actually see the foramen, so I'm depositing just a little bit of product right there. 0.25 cc's. Okay, now let's do the opposite side. So we follow the area of the second premolar right down, and I can actually see the foramen. I'm right next to it. I'm going to inject 1/4 cc right next to the foramen. I'm right on the bone, so I feel the bone. That's it. So now this whole perioral region will be awfully numb, and I've had patients at times tell me they feel like that they're getting no air through their nose because their nose can actually get numb at times. Now for the upper third of the face, you're unable to get, or at least I'm unable to get that type of anesthesia with the nerve block. So occasionally I'll use some of the other products that I have in my armamentarium in order to get a complete, to get anesthesia. So let's start with the areas that are most commonly treated, and that includes the nasolabial folds and the perioral region, the lips. Now, one of the disadvantages to doing these nerve blocks is you may lose some of that fold. So you may want to mark it before you go ahead and treat. Now, I can see where that fold is, and I'm pretty clear on where to go. So I have a good idea where it is, but you have to keep in mind that after you do the nerve blocks, you may lose some of that fold. Here's the nasolabial fold. And my goal is to treat this fold. Now, how I like to do it is a fanning technique. And there's multiple methods. You can do a threading technique. Threading is where you place the needle in and you deposit the product as you pull out. You can do serial droplets where you just put in just a little bit in each little aliquots as you work your way down. Or you can do fanning where you go back and forth. I prefer a fanning technique where I go medial to the fold about 2 millimeters and lateral to the fold to the 2 millimeters, and I fill this whole little lane in. And I'll demonstrate that for you in a second. And by doing that, I believe it raises the whole fold up, and it's a much more natural result. I also believe that it's important to go deeper. I prefer to place it into the subdermis. Some doctors recommend placing it into the dermis. I feel that the results are better if I place it in the subdermis because I think you get a more natural result and you avoid getting a little blue line, which sometimes can be seen if the hyaluronic is placed too superficially. So I place it a little bit deeper to the fold. I raise the whole fold up using a fanning technique, but it does require more product. When you're doing a threading technique, you don't require as much product as you do with a fanning technique. And that brings up another important point, and that is to make sure that your patient recognizes how much it's going to take in order to get a good result. And that's something that needs to be discussed in the preoperative consultation. Oftentimes it takes more than 1 vial of the product, and in fact I would say on average it takes 2 vials in order to get a nice treatment to both nasolabial folds, at least a vial of product, which is about 1 cc of product, in order to get a good result. So it's something I discuss with the patient in detail prior to the treatment, because if you don't do enough product, they may not get a good result and they won't come back, and you'll hear someone say that the product didn't work for them. It's not that it didn't work for them, it's that they weren't treated to complete correction. So I'm an advocate of treating to complete correction if possible. So I'm going to go ahead and start the treatment. Now when you're doing this, it's very important that you fill in this crease, this triangle right here. That's really important. So that triangle you want to fill in. And then I'm going to take the product a little bit lateral to the fold, a little bit medial to the fold. So I'm filling in this lane here. That's the area I'm filling in. So I will go a little bit below, and I use a fanning technique. And this is as I go back and forth, you can see how I'm placing the product in there. I'm using alcohol pen. Now I'm going to take off that blue mark, so that was just for demonstration purposes. It'll be a little bit easier for me to work if I can get that off. And I'm going to do a little fanning method. So I'm coming a little bit medial and a little bit lateral, and I'm going back and forth. And ideally you want to go slow. The slower you go, the less chance you have for bruising and swelling. So I'm moving back and forth, but I'm attempting to go at a slow pace, and this will get you a better result with less bruising and swelling. Now you can see I'm actually below the dermis, and the way you can tell this is by your position of the needle. And I'll show you the different areas you can be in. If you're in the dermis, this is in the dermis. Can you see you can actually see the needle through the skin. That's superficial dermis. If you deposit the product at this level, you will have a blue line that will show up there, and it'll look like a little worm under the skin. It won't look good. The deep dermis is about here, and you can tell you're in the deep dermis because when I push my needle down, the skin will go down with it. It's retracting down the skin. That's in the deep dermis. This is the area of placement which is recommended by most practitioners and even by package insert, and that is also in the FDA indication. I believe putting it in the subdermis, which is a little bit deeper, and you can feel a little give when you get into the subdermis. See, the skin doesn't retract down as much. I'm no longer in the dermis, I'm in the deep dermis, and I like to go, or I'm in the subdermis, I like to place it in that area, going back and forth, filling it in. Afterwards, you can massage it to make sure that it's in the right place. Coming deep in here, moving slow and purposefully. And that's filling in pretty nicely. I may check and see if I feel any areas where I feel like I could use a little bit more. I think right here I feel like it. So I'm going to put a little bit more in there. Moving slow and purposefully so as not to get bruising. Massaging it afterwards. And right away you can see that's filled in pretty nicely. And this is immediate correction. Now, I do tell them they may get a little bruised or they may get a little swollen over the first 24 to 48 hours, but it's usually not that bad. I would say about 5% of my patients get bruising that is of concern. Majority of them do not. I think using the slow technique and this fanning technique works quite well. I like to treat to complete correction. I think it gets me the best result. Okay, so that side's filled. So you see my hand is here, and I see the fold. This helps me to see the fold. And I can go back and forth to see the fold. My pinky finger is on the patient. That way if the patient moves, my needle moves with her, and I won't inadvertently inject her. I start as superior as possible into that triangle. I'm in the subdermis because I like being in the subdermis. I could be in the dermis, which is right here. But I'm in the subdermis now, and I'd go slow and purposefully while I inject a little product. Staying just medial to that fold. And you can see it filling up right in front of your eyes. I come here and I massage that a little bit to work it into place. And now I can work its way down here. Now if I was doing the threading method, it would be like this. And once again, this is a very popular technique. And that's the threading method. And I think it's an appropriate method. I just prefer the fanning. So now I'm going to go back to my fanning technique in the subdermis. I come back up here where I threaded before, so I can fill in just lateral, just medial to the fold. I'm going to work my way down. Now you don't want to get too far down here, because if you do, you can get little areas of fullness in the lateral cheek, which won't look so good. I've noticed on my patients, when I treat to complete correction and when I treat in the subdermis, I get long-term results. And it's not uncommon for me to get well over a year, 12 to 15 months with these patients when I treat as I'm showing you here today. Now in treating the lips, there's a few different tips here. If you look at her lips, she's got nice lips. She's got a vermilion border that you can see. She has some fine lines encroaching on her vermilion. She has some lip body, but she's clearly had some of the effects of aging as her upper lip is thinned. There are those who have a very thin upper lip, and there's very little red show, and in such a case, it's quite difficult to give them additional red show. But someone who already has some red show of their lip, I mean by red show, the red vermilion, I can do some things to bring that up. So with her, I'm going to show you some tricks I have for increasing the amount of red show on that vermilion. So pull the cheek back here a little bit like this, and the lip is on tension, which makes it easier for me to treat. I'm going to do a threading technique where I go to the hub of the needle and then deposit as I withdraw. So I start at the end of the oral commissure. I'm right underneath the red-white lip borderline, and I'm in just underneath the mucosa, submucosa. And I'm depositing product as I withdraw, and you can see it fill up before your eyes. So you can see my needle there. I'm going to deposit as I withdraw. You can see why it's so important to have them numb. I overlap about 2 or 3% from where I finished, and I just deposit as I move along. Now, I have a couple tricks here, because if I want to rotate the lip up and show more red show, I may cheat a little bit onto the red portion of the lip. If I want to work on these fine lines here, I may cheat a little bit onto the white portion of the lip. I'm just depositing as I move along. So I'm cheating a little bit to the red portion of the lip so that I can rotate the lip out a little bit and up. And it doesn't take much to get a nice result in the lip. Usually I use about a half a cc for the upper lip and a half a cc for the lower lip at most. Nice, slow, purposely. You don't want to inject too much. You have to be consistent with your pressure on the plunger, or else you may get little lumps. And Restylane less forgiving in this area. So you want to make sure that you do it nicely and you don't miss any areas. And I palpate the lip to see if I missed any areas. Because if you do, it'll become obvious afterwards. And to me, it feels like I maybe could put a little more in there, so I'm going to come back here and put just a drop in that region. And that looks pretty good to me. Now if I want to try to rotate the lip out a little bit more, I may roll the lip up like this a little bit and put just a little bit into the lip body here, but I'm a little bit deeper here. And I go right along the lip body like this. And this will rotate the lip out. See another vial, please. You can palpate where you put it to make sure you didn't miss. That feels pretty nice. Okay, now we're going to do the lower lip. So put your lip out like this. She doesn't feel her lips. So I retract the lip, so I'm on retraction here. And once again, into the lip border. Now this 30 gauge needle I think works very nicely here. So that's my preference. And I'm right at the red-white lip border junction. I'm staying at a consistent depth, consistent speed, and consistent in how much product I deposit. All the way across the lower lip until I get to the other side. Okay. I think that looks pretty good. Now you can also put a little bit into the lip body itself if you want to make the lip roll out a little bit and a little more red show. Ideally you want the lower lip to be a little fuller. You want your upper lip to project 2 millimeters beyond your lower lip. I palpate the lip to make sure I didn't miss any areas, to make sure she's even and symmetric. She is. Now, of course, you have to recognize that she's got a nerve block, so her muscles of her perioral muscles are not functioning 100%, so they may have some asymmetries from their of their lips. Let's say you pucker, so you can see that she's not puckering appropriately, so you have to recognize that this area has a little less function than the opposite area, so it may look a little flatter, but that will come back. So you have to make sure that you put a consistent amount on both sides. Okay, so that's treating the lips. Some people will treat the fill-through columns. That's an option. I don't frequently do that, but if you were to treat that, one way to do that is to just place the needle up into the fill-through column. Just deposit a little bit as you come down. There's another area. It's not an area I treat too frequently, though. Okay. Now I'm going to show you a little something I do to raise the corner of the mouth. This is an area where you often have a downturn. So one of the little tips for doing this is I have the patient open their mouth just a touch, and I stick the needle into the oral commissure, but just a little bit below. So I'm just a little bit below the oral commissure, and you can see where my needle is right there. And I deposit product right into the oral commissure, and just a little bit below to support that buttress. And you'll see the corner of the mouth come up right into there. Okay, I can take my hand here, massage it. And you can appreciate how that corner of that mouth comes up. Next area we'll go to treat is the pre-jowl sulcus. This is purulane, and because it's a thicker product, we use a 27 gauge needle. Right now I'm using a 1/2 inch needle. You can use an 1.25 inch also. And because it's thicker, you have to use a larger lumen so that it can be expressed without too much effort. So the pre-jowl sulcus is right in this area right here. Here's the jowl, and this is the pre-jowl sulcus. So this is another area that we will treat. When we treat this area, you want to make sure you get underneath the border of the mandible, because you have to put a little bit underneath here to make sure you treat it appropriately. Now she doesn't have significant pre-jowl sulcus, so we'll just put a little bit in there. I go down, and you want to inject slowly and purposely. Now you want to stay medial to the jowl. If you inject into the jowl, it will cause worsening of the jowl, and it'll actually be an outcome you won't like. So I placed there about 0.2 cc's, and we're feel it, massage it into place. And I can start to see that. And I still see a little depression in this area, so I'm going to put a little bit more in there. I come a little bit around the inner surface of the mandible. Just injecting in a fanning method. Now I'm deep here. That's one of the things I like about this product, the deeper version of the product, is that I can volumize the face. So I'm not in the dermis, although many may recommend being in the dermis. I like to be below the dermis here. And we'll fill in a little bit more right here. And it often takes a little more product to do this, but the results are quite worth it. So massage it into place. Okay, so I think that's appropriate. That looks like it's filled to completion. Now we'll do the opposite side so that we have a symmetric response. And I can see that area right there. Turn your head this way. Chin down. Making sure to stay medial to that pre-jowl sulcus. And then massaging it afterwards. And coming a little bit underneath the mandible. So we're going to continue in the lower 1/3 of the face, and this is an area I will sometimes treat as the mentolabial sulcus. It's not too often I treat this, but occasionally I do. I come into the deep dermis, and I do a threading method here. Threading method here. Okay. So that's the lower 1/3, and oftentimes we'll just give them an ice pack afterwards. Here's the nasojugal groove, an infraorbital hollow through here. I'm going to draw infraorbital hollow, and then this is an area of the cheek that so we may try to accentuate this, but fan it into this area. You don't want to put too much product in here because it can get lumpy and not look good. But this area, we can replace some volume that's been lost in here. So that's an area to fill. Now, there's multiple ways of doing this. It's not anesthetized like the other areas of the face because the nerve block doesn't work in this area. So oftentimes I'll use a topical spray, or something new we're doing is the intraoral approach. So first I'll show you the topical spray. I like makeup pencil because it comes off much easier than a marking pen. So if a patient wants to show me something, we'll give them a makeup pencil. And that's a way for them to show me where they want to be treated to. And I can also demonstrate to them where I think they should be treated. So my assistant usually helps me here. And I'll cover the eye because I don't want to make sure to get this product in the eye. And we may cover the corner of the mouth. And I find the area I want to treat, which I know is right around here. And this product gets sprayed onto the skin until you see a white color, like that. Okay, and then the product. Now, you have about a minute or two of it being anesthetized. And I know the area I want to treat is this area, so I'll come into here and I use a fanning technique. Once again, slow and purposeful movements, consistent amount of pressure on the plunger as I fill in this area. Now this can produce a significant amount of bruising, so I do want to go slow in this area as I fill in this area. Massaging along the way. And I'm filling in that whole area I painted out for you before with the makeup pencil. Okay. It takes quite a bit of Perlane to fill this area in, or for any filler for that matter, so I do really need to use quite a bit. Now, one thing I'm doing recently is I'm doing intraoral techniques in order to treat the cheek area. So I'll take a betadine swab the intraoral mucosa, and then using the larger particle product, I'll use a 27 gauge needle. So I'll go intraoral into the sulcus, and I'll turn her head this way because I really want to make sure I'm careful where I know my needle is. And I can feel where my needle is. And I'm injecting intraoral here into the area of concern. And my hands are here and I can feel the product being deposited. And this prevents a lot of the bruising and swelling. In addition, it's much less painful. And I think it gives a very nice look. So this is something that recently we've been doing. Okay, good. Okay. And you can start to see it filling in already. If you look down, you can see how this is filling in here. So now I'm going to treat the region, the nasojugal groove right here, and infraorbital hollow. What I do for this is I march the product out along this region. I'm using Restylane with the 30 gauge needle, and the reason why I'm using a 30 gauge needle is because I want to deposit just a little bit. You could use a 32 gauge needle, but I find it very difficult to squeeze it through there, but that is an option. I like to place the product very deep. I think it works better if you place it deep. I think it's very important to undercorrect in this area. If you treat to complete correction, you will see a lot of blue blebs that will form within the next couple weeks. So I think it's very important to undercorrect in this area. I can't emphasize that enough. And allow hydration to occur and for the area to be corrected. but do not overcorrect in this area. In fact, do not correct to complete correction, undercorrect. So I'll often use no more than 1/4 cc in this area, and I think that's adequate. Once again, I like to place the deep. I think superficial, which is favored by some, is appropriate, but it's very difficult to do well, and you're at risk for getting blue blebs. So this is the infraorbital hollow. I keep my finger on the orbital rim, so I know where I'm at all times. I'm protecting the orbit. It's kind of hard to see there, but I'm going to place my needle down onto the bone. So I'm down on the bone, I feel the bone, and I deposit just a little bit. And then I move along. Deposit just a little bit. Now this area is often anesthetized with a little bit of topical anesthetic, and that's all that's required. As you can see how it's placed there with it, that sit there for 15 to 20 minutes, and that's all that's usually required in order to give anesthesia in this area. So I have my fingers protecting the globe, and I go down to the orbital rim. I feel the bone, and I deposit just a little bit. Depositing just a little bit onto the bone. So I'm at the bony rim, depositing just a little bit. And make sure I feel the bone, and deposit just a little bit. Turn your head this way. So frequently I'm like this. I know it's difficult for you to see, so get down to the bone, deposit just a little bit. I'm massaging it as I move along. I'm just marching along the rim. This area frequently bruises too. Once I get to the nasojugal groove, make sure I'm deep. There's a lot of muscle in this region. For that reason, this area tends to bruise a little bit more from bleeders within the muscle. I'm going to turn your head back this way. I'm going to fill in this area a little bit more right here. All right, once again, you want to make sure you're not superficial, because if you get too superficial with this, you will for sure see it. Massage a little bit. I think I use a little bit more right there. Deep. Now some people will do a very thin layer just underneath the orbicularis like this, and just lay little whispers of product down. I don't like doing that. I think it leads to little blue blebs, but it's an option to just go real superficial underneath orbicularis and just deposit a little bit. So that's an option, so I don't do that. And that's it for treating around the eye. I undercorrect. Actually, I think you use a little bit more right there. Okay, so that's it for treating under the eye. Once again, undercorrect is the important point. Okay, and we'll give that about 2 weeks and see how that looks. Over the next 2 weeks, I find that the area gets better and better. Now another area I'll treat is just under the brow here to elevate the lateral temporal brow. So one of the ways to do that is I do a threading and fanning technique underneath the lateral brow, and you'll see I'll give it a little bit of an elevation. So I like to use, you could use either Perlane or Restylane in here. Since I already have Restylane in my hand with the 30 gauge needle, we'll go ahead and do that. Underneath the tail of the brow, just deposit a little bit there. Threading method. And I come out here over the orbital rim, underneath the brow. massaging it into place. You don't require a lot in this area in order to get a nice look. In fact, too much gives a very masculine look. So just under a little bit of the tail of the brow, staying lateral, will give a little lift to the brow. I will also treat the glabellar area, which is right in here. If the glabellar creases are still evident, even though I spread them apart, then they're a good candidate. Most of her glabellar creases are eradicated by me spreading apart, so therefore she could benefit from Botox alone, but the combination may be helpful. If you do it in this area, you have to be careful. There's been reports of necrosis with both collagen and fat in this region. Therefore, I'm very careful when I inject filler into this area. I use a serial droplet method. I stay superficial and I inject slowly. And I think that's the important part. If you go too deep, theoretically, you can obstruct an end artery and cause necrosis of skin. So we do stay superficial and we deposit slowly. If you were to hit an area of which there appeared to be impending necrosis, you'd see a mottled appearance to the skin, and right away you should treat it with massage. Stop the injection, treat with massage, topical nitro paste, just a dab, and intraarterial injection of hyaluronidase has been shown to actually improve that impending necrosis. So I would be ready with hyaluronidase. So I have hyaluronidase ready in my office in case I would need it in a pinch. So when I have them frown, relax, and I will go just into the dermis. And here I'm really truly in the deep dermis. And I inject into the crease. And this is the serial droplet method we had talked about earlier, where I just put little droplets. I like to go transverse to the crease and slow. And I think this is the result, gives me the best results. See your frown? Good, relax. You can see how that's filling in very nicely. Now between this and botulinum toxin, she should be very happy with the result, and those creases should not be evident. So serial droplet method, just moving transversely along the crease, going slowly so as not to get a necrosis. If I see a white blanch, I'll stop immediately and massage the area. And there's a little white blanch, so we'll stop, massage the area, make sure we have reperfusion, and we do. Now we'll go back, follow it down. And I'm staying in the dermis this whole time. Not much product is required to do this. Maybe 0.2 cc's or so. Okay. And let's see your frown. Okay, good. I think that'll give her a nice result in that area. One area that recently we've started treating that's been popular is the earlobe. If you decide to treat the earlobe, for someone who's got an aging earlobe that starts to hang, sometimes there's creases in the earlobe, and it's much more dependent. You can place a little Restylane in there. She's not someone who particularly needs it, but for demonstration purposes, I just place it right into the soft tissue of the ear. And some women tend to like the way that looks. They think that their earrings are demonstrated better after filling this in. So I just place a little bit in there and just massage it into place, and thickens up the earlobe, allows the earring to hang a little bit nicer.